Hello, everyone, and welcome to Substance Use Across the Lifespan, Supporting Every Stage, an immersive podcast, toolkit, and workshop series created in partnership with the Opioid Response Network. I'm Marlene Martin, an addiction medicine physician and longtime member of the MRSA community. For those new to the podcast, MRSA is a national organization dedicated to bringing together disciplines and perspectives to strengthen substance use care through collaboration, evidence based practice, education, and advocacy. This podcast series explores how substance use care evolves across the lifespan, from childhood through older adulthood, highlighting the developmental, social, and clinical factors that shape care at every stage. And now, let's turn to the first episode of the series. Older adults are the fastest growing population in opioid treatment programs. Yet many treatment models were not built with aging in mind. What does age friendly addiction care look like? And how can opioid treatment programs better support patients with complex medical needs, mobility challenges, and changing social supports? In today's episode, we explore how opioid use disorder treatment must evolve to better support older adults and reduce fragmented, age insensitive care. If today's conversation sparks ideas for your own setting, we invite you to continue your learning with this episode's companion toolkit and live workshop. You can download the toolkit by completing the episode's evaluation survey and then join us for the workshop, where we'll take a deeper dive into improving care transitions and expanding support for older adults in skilled nursing and post acute care settings. You'll find both the survey and workshop registration links in the show notes and at immersa.org. Joining us today is our host, Dr. Benjamin Hahn, a geriatrician and addiction medicine physician at UC San Diego and the VA San Diego healthcare system. His research focuses on improving care for older adults with substance use disorders. He is joined by Dr. Zoe Weinstein, Director of Boston Medical Center's Addiction Consult Service and Site Medical Director of a methadone clinic, and Dr. Kathy Eggert, Founding Director of the APD Foundation's Access Center and a leader in low barrier opioid treatment models. Presenters report nothing to disclose. Thank you for joining us. Let's begin.
Thank you, Marlene, and welcome everyone. Thank you for joining us. I'm your host, Benjamin Hahn, and today's episode focuses on the care of older adults in opioid treatment programs. We're joined today by Kathy Eggert.
Hi, I'm happy to be here.
And Zoe Weinstein.
Hi guys, nice to talk to you all today.
Are two incredible guests with experience in the care of patients in opioid treatment programs. We're so glad you're here. To help frame our conversation, I'm going to start by sharing 3 learning objectives. These are the key themes we hope you'll carry with you after listening. First is to assess the challenges that older adults may experience in receiving care in opioid treatment programs as they age. Second is to describe the importance of utilizing the geriatric's 5Ms framework in the care of older adults with opiate use disorder. And finally, third is to provide practical ways to implement age-friendly care in opioid treatment programs. As you listen, consider how the needs of older adults are currently addressed in your setting. Let's get started. So to begin with, for some context, the number of older adults who receive care in opioid treatment programs has been increasing sharply since 2012, corresponding to the second wave of the opioid overdose crisis that saw increases in heroin-associated overdoses with tightening of the use of prescription opioids nationally. Additionally, Medicare began covering opioid use disorder treatment in opioid treatment programs in January of 2020, further increasing the number of older adults. Generally, we think of an older adult as age 65 and older, but we know that age is just a number, and that people with opioid use disorder have a high prevalence of other chronic diseases that can accelerate aging, including age-related geriatric conditions such as falls, incontinence, cognitive decline, and frailty. The result is that many opioid treatment programs are increasingly caring for adults with multimorbidity, serious illness, and functional limitations, which can create unique challenges. So to begin, as directors of opioid treatment programs, I'd love to hear your experiences over the years in caring for an increasingly older population. Maybe we'll start with you, Kathy?
Sure, thank you. First, I just want to say this is such an important topic. The clinics that I work at have seen, as you're describing, a huge increase in the number of older folks, and you know, there are both challenges and wonderful opportunities. It's a great population to work with. They come with so much life experience to both honor and support what their needs are. The challenges, things like mobility is just a key issue. And in some of our programs, the buildings are really challenging. And I'm sure that's common across the national spectrum.
Oh, and how about for you, Zoe? What have your experiences been?
Yeah, no, I really agree with Kathy that I would say the multiple opioid treatment programs I've worked at, there are a range of ages, but we definitely have a large cohort of older adults. And it's very fascinating learning from them, talking to them about their experiences and treatment over the years, that how the drugs supply has evolved over the years. And they also have, as Kathy said, a fair number of specific challenges with older age, all those comorbidities, those medications, the physical space that Kathy already pinged on. I'm thinking about we had some very bad snowstorms recently in our part of the country, and that really impacts people's ability to travel and travel safely and not slip and fall. And so I think really focusing on how we can optimize care for this very important patient population is very worthy of our conversation today.
And I'm curious, how do you think older adults in general do with their opioid use disorder treatment, specifically in opioid treatment programs, compared to younger adults?
Uh, it's an interesting question. I think that overall, both populations can and do well utilizing methadone. Given the age differences, there's some just natural differences in who they are, and what their life circumstances are. Younger folks are raising families and probably more actively working, and those pose different barriers than our aging population that may not be involved in work and as such are socially isolated or because of their substance use disorder. I mean, true in both populations, but with the older adults might have become more isolated, which add different challenges. And I'm going to bounce it over to Zoe.
Yeah, I mean, I'd say I've done some research. I know this is not a research podcast, but there's some research showing that older adults generally kind of are retained better in opioid use disorder care of all kinds. And I, I think our goal is obviously to maximize retention overall because retention rates in all forms of medication for opioid use disorder are really inadequate. And we know being off medication is fatal. And so I think while older adults, may have some just kind of on a population level, generally better retention. They do have a lot of these specific barriers to care. Obviously medications only work if you take them. And so if you can't travel to the clinic and take your medication, it's hard for it to be effective. Also, the comorbid diseases, I'm thinking of patients I've seen this week, with co-occurring cancer who have very demanding chemotherapy treatments and or just are very nauseous or ill and can't really get out of bed from their chemotherapy treatments, or patients who are on dialysis and again have multiple demanding medical schedules. And I think, it can be, very taxing, the requirements of, frequent attendance at the clinic when people are trying to also manage those other conditions.
And I'm just going to add, as you're talking, Zoe, I'm thinking about, our folks that go in the hospital and are maintained in the hospital, but then require a skilled nursing facility. And that's just a huge barrier for this population.
So I think as a geriatrician, that the key time that I'm always worried about is the transitions of care. And so, the transition from hospital to SNF to home, I think is a vulnerable time for people, especially with opioid use disorder. I'm just curious if there are any other specific challenges that you faced in your roles in managing opioid use disorder in this population. Zoe, maybe I'll start with you.
Yeah, I think some of the things that I think about that we kind of touched on briefly are kind of the social isolation, social supports, and that unfortunately, as we know, like opioid disorder is a very fatal disease for many, and so people may have lost a lot of their friends, family over the years due to overdose or other, drug use related comorbidities. And so I think figuring out how to help people in older age kind of enhance their social network, and especially like a network that supports their recovery goals, I think is important. We have a lot of group-based counseling and things like that that are offered at the OTPs that I've worked at. And again, like having groups that are relevant and supportive for people at all their different stages of life, like Kathy was talking about. Some people, might have childcare issues, even as a grandparent. They might be. We know that a lot of people have lost children to overdose, right? And so they might be taking care of grandkids, or just having groups and services that are more reflective of their reality day to day, that make people feel like they're more eager to engage in, and are reflective of their individual goals and challenges, I think is something important. And then we talked some about kind of general comorbidities, but obviously co-occurring pain is a big factor. And sometimes patients have had challenges, for example, getting surgeries, like orthopedic surgeries due to history of substance use. And so they might really have a lot of chronic or ongoing pain. And so thinking about how to optimize their methadone, either through like split dosing or kind of coordinating pain medications with their primary care doctor, I feel like becomes pretty important as people age or have those, as you said, Ben, kind of like age-related illnesses, even if they're not technically old, because I think those kind of come up a lot.
And one of the points I want to echo in on with Zoe is you're talking about age-appropriate services, selections, allowing for people to have choice with the selections. A lot of times we prescribe what group somebody should go to or when they should come to a service. So allowing people to be able to select, hey, I am interested in this group on grief, or I'm interested in this group on whatever the health-related issue may be, as opposed to a specific counselor-driven topic, giving people a rich menu to pick from and allow for them to select what times and what topics they might be able to come to, as opposed to a group prescription of you'll come at this time. I mean, when we're talking about barriers for older adults, with mobility and transportation, um, giving as much selection and ability to choose is really important.
Right. So it sounds like flexibility is an important thing for this population, which
Yeah.
I know in the OTP setting may not always be flexible for all people, and so I think that probably is one of the barriers I'm hearing.
Yeah. Ben, we've moved to what we call an open access model, and that is one of the things we do is really allow people self-selection and try to look at what topics people are looking for in their care and train ourselves to be able to provide that kind of group or that kind of topic.
Yeah, and I think to your point, Ben, traditionally, OTPs have not been very flexible. Now works in OTP for over 10 years, shocking to say. Uh, and I think
I won't tell you how long.
But, you know, there have been a lot of existing flexibilities that have been there the whole time, which I think we're going to get more talk about, like medical exception take homes. Now, with kind of the take home flexibilities from SAMHSA in general, we really are allowed more explicitly to take into account people's frailty, medical needs in a kind of more holistic assessment of the risks and benefits of take home doses. And so I think that's pretty important. For us to understand, like, and that's something we try to do is like, well, what is this person's chemo regimen and schedule? And like, when is it realistic for them to come in? And what weeks will they be feeling sick? And can we time their take homes to kind of align with that? Like, I think it's really about collecting the information, and then, which, I is a first important step is really understanding like kind of what are the individual needs of this person. And then really thinking about what levers, what tools do we have to kind of get as good a fit as we can. Um, Again, with all the challenges that we've talked about, right? Like we can't necessarily change the physical space of our clinic completely, right? Like due to NIMBYism, a lot of times we're kind of stuck maybe in the building we have, but are there some accommodations we can make? Or, maybe we don't feel comfortable giving this person a whole month of take homes, but we can time their pickup days around their other medical needs, et cetera. So kind of how can we use the tools that we do have at our disposal as optimally as possible?
Great. Yeah. And so, that kind of moves us to our next part where I'd love to expand on this and think about how we can specifically address some of these issues and what are some of these practical strategies that you've already mentioned to better care for older adults in OTPs. So just as a geriatrician, I do want to highlight that there is a movement towards making our healthcare systems age-friendly to improve the care of older adults. And so this focuses on 5 evidence-based elements of high-quality care for older adults known as the 5 M's, which include addressing mobility, so that includes preventing falls, optimizing function, mentation, identifying and managing cognitive impairment and mood disorders. The next M is medications, so minimizing polypharmacy and drug-drug interactions, multicomplexity, providing holistic and whole person care, and finally, what matters most. So really aligning care with the patient's goals and preferences. So I'd love to focus on a few of the 5 M's and see what existing strategies or tools can be used to make care more age-friendly in opioid treatment programs. And keep in mind that the ideal approach isn't always possible. So I think the first M's I want to focus on are the multicomplexity and medications, because I think one of the challenges for me caring for this population in the primary care setting or as an inpatient is that opiate treatment programs largely remain separate from the rest of healthcare. And so for both of you, how does this come up for you when caring for this population?
Yeah, I mean, I think that comes up on day one when I admit the patient to the OTP, when I ask them their medications. And we go through a whole informed consent about what are the risks of methadone. And I spend a lot of time, because we have a pretty medically complex patients at my clinic. We get a lot of patients who are coming to us from a hospital. So a lot of conversation about, why do I want to know these things and why do I care? Am I just being kind of nosy? It's really because of unfortunately, methadone is this amazing medication, but it's one of our most life-saving medications that we have across any disease. However, it has a lot of drug-drug interactions. And it does have, some rare but serious risks, including, fatal arrhythmia. And so I really go into explaining why I care to know which medicines you're on and why it's so important for your other doctors to know you're on methadone, before I try to ask them to sign a release, and things like that. And so I really try to make sure people understand the rationale, um, because I think that it is important, one, for them to understand the risk of the medication that they're taking, and two, to understand why it's important that, I ideally be able to communicate with their other providers. And I understand people feel like there's a lot of stigma associated with the treatment of itself, of methadone. Unfortunately, there's stigma of opioid use disorder, there's stigma of the medication. And so people might be reluctant to have their providers know about their methadone or have a release signed. And so usually it's a pretty intensive part of my medical intake, honestly, is all around that conversation, because I think it's an important for patients to feel heard about their real concerns, maybe about disclosure, and us to have an honest conversation about, why it's helpful for me to have that information.
Yeah, Zoe, that's so important to say. It goes even further than the feeling of stigma. It's fear. I mean, people have been punished, unfortunately, by unknowing physicians or physicians that have not been experienced in working with this population, and a lot of fears around medications themselves. So, being able to help support that client make those decisions and in having those conversations. And as providers, really reaching out to the other providers and saying, hey, look, this is the rationale for why we want to coordinate care. Here's, what our experience is. I find those conversations between prescribers so important, and the healthcare providers in general. Once we can have a patient sign on so that they do feel safe and that they do feel like they're being heard. So I like that you raised that point. Thank you.
So one thing that I've encountered many times are older patients who receive methadone opioid treatment programs who also have other chronic diseases, but because of stigma, they don't feel, the only place to get medical care or any kind of care is in the opioid treatment program setting or unfortunately in the emergency department. So how do you approach patients who really don't have outside care, but have complex medical issues?
Our program has worked to and has been on the forefront, I will say, of always having integrated care. We have good access. We have a primary care unit attached to our organization. I know that's not possible with all OTPs, but to work and create partnerships, to create MOUs, to be able to partner with other physicians or other community-based healthcare providers, so that there can be a really strong relationship and ensuring that people are getting the ongoing care that they need.
Yeah, so I would say, like, we don't have formal integrated medical care at the OTPs that I work at, but I have another day job as a primary care doctor. And so, I think sometimes I literally am like, you could come see me or one of my colleagues, or, I think we have a list of, like, we call them, like, kind of substance use disorder friendly providers, where we're like, these people, prescribe buprenorphine, like, these people really want to work with patients with substance use disorders. They would be, like, happy to have you. And so I think really making sure that people know that there are providers who are eager to work with them and trying as best you can to have a warm handoff. We do, some OTVs we've had over the years, tabling at the front from, community providers or, social service providers who are tabling there saying, hey, you can, on Wednesdays, so-and-so's tabling and you can get a flyer, or you can meet with them and hear about their program, even if we can't provide you integrated care here. And again, that's something that comes up a lot in the medical intakes when I'm talking to people about that they aren't on medication for their mood and how their untreated mood might be a trigger. Okay, like, let's work on how we can maybe connect you with somebody to help with that. Or a lot of patients maybe don't have their Hep C treated. Okay, so I think trying to figure out, how we can facilitate engagement and how we can directly address the fact that, people might be avoiding medical care because of their previous experiences of stigmatizing behavior. And so how can we, you know, link them to providers that we feel like are going to be welcoming and energetic to take them on.
So I'd like to now think about the 5 M's for people who have issues with mobility or at risk for falls. Is there anything we can do in the opioid treatment program setting to make it more age-friendly for them?
It's a challenge when you think about space. I mean, some of this we've mentioned previously, but it's worth noting again. Space issues. I work in 2 different clinics right now, and one is so space challenged. It's an old program, and it's an old building that is very limited. But things like, can you put a bench up in the medicating area? Simple little ideas. Is there a quiet space right off the medicating area that can be created a safe office space so people don't have to travel far? And Zoe, you mentioned earlier, things like medical exceptions. How do we do that better? And I'll let you pick it up from there.
Sure. Yeah. So I think for people who don't know, so there's something called a medical exception that from the days from forever, you can basically submit to your state regulator and the federal government saying, I'm going to give this person medications that are beyond kind of what would be what we used to call kind of their earned take homes, or kind of by their take home criteria, how many they should kind of have. We're going to give them extra because of this condition, or we're even going to give the medications to somebody else. So we're going to give it to a visiting nurse, and the visiting nurse is going to pick up the medications in a lockbox, bring it to them. We had a patient I mentioned with the snow who was unable to kind of physically get out themselves this week. And so we had a trusted family member come get their medication and bring it to them. So thinking about how can we, use these processes to document and still have good safety and medication tracking, but make sure that people get their medications. And there's a whole variety of other strategies too, which we use a lot during the COVID pandemic, which we call kind of colloquially car dosing, but you don't have to have a car, kind of outside the clinic dosing, right? So someone comes and says, oh, actually I have a terrible, contagious disease. We don't let them in the clinic, right? We put on, protective equipment and we dose them outside, and we can do the same thing, right? They're like, I can't stand up and get out of my car today. My wheelchair's broken, whatever. So I think thinking about, there are a lot of flexibilities that we can do every day, whether it's kind of those informal things like kind of car dosing or more formally having a relationship with multiple visiting nurse companies so that when your patient is becoming more frail, is having falls, is having, active chemo treatment, we actively reach out to the PCP. That's another reason we say we want to have a release on file so we can call your PCP, so we can call and tell them, can you help us get a VNA? Like, we want you to have a VNA. We don't want you to have to come in here all the time. I think we talked about loneliness a little bit, that some people want to come in. They like the socialization aspect. But if yeah, when I have patients telling me it's really hard for me to get in here, and if for whatever reason we don't think they are able to safely manage a large amount of medications independently, either because of ongoing substance use or other things, they might have memory issues, dementia, visual impairments we have a lot of. And so maybe they can't safely handle weeks of medication unsupervised, but with a visiting nurse, that person can be in their home helping co-manage their medication and mean that they don't have to physically come in, which is sometimes sad. I miss seeing them. And these are all options that we've had since the beginning of time or my time. So I think a lot of these are underutilized, though. I'll hear sometimes from a primary care who reaches out to me about setting something up like a VNA for their patient. They'll say, thank you for being responsive. Sometimes when I called other providers, they haven't been willing to work with us so I think this is really a call to action. If you are an OTP provider, to just kind of maximize your utilization of those flexibilities. And if you are a PCP, or other care team member, give us a hard time at the OTP and say, are you sure there's nothing you can do? Have my patient not physically come in there. I think I was telling Ben and Kathy in one of our prep meetings that I had a patient who was, the doorway to the clinic was so narrow with his wheelchair that he was like getting injured physically coming into the building. And we really had to figure out a way for him to not come into the building. And so I think that's just, we have to really be realistic about what's happening and really be creative and brainstorm. And I think there usually is, some imperfect solution that we come up with.
Yeah. And you mentioned family. A lot of our folks don't have Medicaid. They might just have Medicare, so that's prohibitive with getting VNA services. So getting creative, and is there a family member that can be supportive? Is there a friend that either lives in the home that can help them manage their medications in a safer way? I'm thinking of a gentleman that had breathing issues who overall was doing really well, but once in a while would get a little bit forgetful, and he has a significant other that we had not thought of, and he said, I've got people in the home. Can't get visiting nurse. We said, oh yeah, let's call her. Let's figure that out together. So, it was really nice to be able to, problem solve with the client and include them. And what can you think of? How can we help promote you getting what you need?
Yeah, I really like that, Kathy. I think that full team, like, let's all brainstorm together, the medical director, the clinic director, the counselor, the patient, what could we be doing differently so that you can get your medication reliably and safely? And I think that's something that's been really helpful with the changes in the take-home regulations is that, I think it's opened up the reminder for a lot of folks that sometimes it's risky to not give somebody take homes because it's just not realistic that they're gonna come in. If you don't give them those weekend take homes, they can't get that ride on the weekend. They're like, we're just gonna miss our doses on the weekend. So we have to think of something else. And yeah, I think really brainstorming with the patient and engaging the family or trusted friends, is really helpful.
And don't underestimate the power of those missed doses. Those missed doses contribute to people falling out of treatment, potentially overdose. I mean, you could be setting somebody up to die.
And so I think you mentioned a bit about medical exceptions. I was wondering if you could talk a little bit about that, because as a PCP, it's hard to know what flexibilities are available in the OTP setting. So the medical exemptions are things that you as clinic directors would put in, or is that something that I would help facilitate, or how does that work?
It's a process. It's a regulatory process. we as clinics have very stringent guidelines as to what we can and cannot do with the medication. And for us to give out medications by an exception, meaning that we wanted a VNA to pick up the medication, that would require a state and federal level exception and sign off. So we as the providers, our medical providers, have to submit that into an electronic system that needs to be approved.
But what the PCP can help with is the documentation. So I oftentimes, for example, the PCP will maybe send me or fax, fax a letter or verbally tell me, this is the reason why my patient can't come in. These are their medical and mobility issues. Hopefully, the clinic knows that too. But, sometimes we don't have that level of detail or, like these are the appointments. So basically you as the PCP can provide the supporting document. And I regularly get communication from a PCP saying like, this is not realistic for this person to come in, more than once a month because of these various medical conditions. And, if they don't qualify for, kind of standard take homes at that level, like I'll happy to collaborate with you on getting them a VNA. So we do have to submit these to the state and federal government. And, it does depend on your state, to be transparent, how these are approved or not. Um, and so it's not completely in the clinic's control, but I think like everything, the stronger argument you provide, the more likely it is to be approved. And typically you do have to resubmit these multiple times a year. So presumably the justification for somebody who has, whatever stage 4 cancer is unchanged, or someone who has, kind of spinal stenosis and no operative options is unchanged, and you kind of keep resubmitting it. But obviously sometimes people get better and they no longer require those. So it is something, it's a regulatory and paperwork burden on the clinics. And so sometimes clinics are not so eager to do it just because it is an extra system, an extra piece of work. So I think having the PCP explain kind of why it's important from their perspective is very helpful for us.
Thank you. Okay, so finally, I think it's very important to talk about what matters most of the 5Ms, because we are seeing more older adults in this setting having issues around dementia, as well as advanced cancer and pain from metastatic disease or other serious illnesses. These include patients who may have been on methadone for decades or newly entering treatment. So how have you both navigated the care of patients who may need more of a palliative care approach or have really serious illness that really is life-limiting?
In an ideal setting, it would be easy for somebody in a palliative care situation to be able to receive methadone outside of an OTP, um, and just have that continue, to not have some of the regulatory barriers that we have. I mean, there's pros and cons to that. The con would be, the OTP does provide a certain amount of social support, and for somebody who's been coming to the clinic for decades, that's pretty meaningful. Um, but it really truly would be easier if somebody was in hospice, um, that providers were allowed to really just pick up the methadone. Zoe, you wanna add to that?
Yeah, I would say I feel like that's an area where I personally have felt a lot of good success with patients who are well established in the clinic. We know them for a long time. We have contact with their providers. Their geriatrician or pal care doc is in touch with me saying, hey, this person is really enjoying still coming to the clinic, once or twice a month and still is able to do it. But I think in 3 months, Zoe, I'm going to take over this methadone. And we say, okay, we make a plan. And like, that's like the optimal scenario where, and by the way, reminder, I'm prescribing them that oxycodone for breakthrough pain, and please don't suspend their take homes when they come back positive for oxycodone. And I go, okay, I remember. So, and I have definitely had the optimal scenario where, we have good communication, we have a good runway, we kind of have a plan, and we do transition people kind of from basically shared palliative and OTP care to complete palliative care. Where I've had the most challenges is usually people who kind of come onto the OTP kind of late in terms of their disease, and maybe their palliative care doc doesn't know them as well, or their PCP doesn't know them as well. We talked a lot about people maybe avoiding care, right? So somebody who's unfortunately kind of entering care with very serious cancer diagnosis and entering OTP care. And so we're trying to get them through all of our regulatory checklist of like intakes and things like that. And so I think that I have seen that kind of be a rougher, at least weeks or months for people, because again, they're kind of doing all of these required orientations and sign-offs and so it would be great if we could probably get them, you know, take home methadone faster, and if maybe we could get them transitioned to more full palliative care faster. But I do think for me, that's where things are sometimes rougher. And I think we try again to like be as creative as possible and sometimes say like, okay, take these take homes for now. And like we'll do the group on the phone this week, trying to be flexible, but I think it's harder to accommodate people who are newer to the clinic just because of all the check boxes that the clinic is supposed to do.
Right. And so one thing I think many of my palliative care colleagues, sometimes they do feel uncomfortable if someone is still actively using substances, if other things are showing up on their urine tox. And I think that they feel it might be better to receive the methadone through an OTP rather than them, just because of that, uncomfortable, situation for them, and maybe they're not familiar with. And also, some of our patients with serious illness, they'll need palliative care for 1, 2. It's not oftentimes it's not months. Sometimes it's years. And I don't know if that's come up for you or ways to address that.
Yeah, I think it's a bumpier road. Zoe kind of said that, used that term before, but so I'm going to use it again. I had a client that had liver cancer and was not doing well. She was continuing to use, and she was a really cool lady and very outspoken. She could be, right in your face right up until the end, which is one of the things I loved about her. So she made it challenging for providers in some ways because she was such an advocate for herself and so outspoken and colorful, I will add. But we just had a hard time getting all of the prescribers on board with really helping her, seeing what she was going through and being comfortable with she's using, but she's dying. So how are we going to really take care of her? And I think, we have a ways to go with understanding that people may continue to use substances or will continue to use substances in the face of really challenging situations.
As Kathy was alluding to, all providers have their own risk tolerance, right? And that's like the joy and the challenge of multidisciplinary or collaborative care, right? It's like you have your risk tolerance and other people have their risk tolerance, and you can try to kind of talk to them and explain your rationale, but we can't control what other providers do. And I think it is still about trying to make the best of situations. And I think on in the other hand, for us, like we have a lot of our patients where a VNA comes every single day to give their medication, and on hospice, usually you can't have a nurse every single day, and you definitely can't, probably not for 6 months or a year. So sometimes, I've had patients where it doesn't actually make sense for them to transition to hospice nursing because they actually would lose services compared to when they have the VNA. And so I think things like that, like, okay, you're concerned about this person and their medication and monitoring. Well, what if you had the VNA come every day? So I think, suggesting to them a lot of the solutions we've come up with, right? Of like the trusted family member, or like, are there other impairment or sedation concerns? Or are we just talking about what's in their urine toxicology screen? And those are kind of different things. And so I think, yeah, at the end of the day, you know, we can advocate for our patients. We can coach them how to advocate for themselves. But I think we have, keeping on working with creative solutions. And I think, unfortunately, the OTPs, fall within kind of our larger healthcare system, which just has a lot of gaps. And as much as we can do to bridge those gaps is, of course, a benefit to our patients. But the system, the structures, a lot of it exists sometimes beyond our control.
Yeah. And as much as we can keep that whole person, as you're saying, and not focus on a single aspect of who they are, meaning their urine screens or a colorful presentation. Um, it's about really keeping dignity for that person.
Right. And so I think that the what matters most is really, it's hard to align patient goals when oftentimes our health systems are more policy based, rather than actually patient centered. And so it's challenging to kind of align that for patients. But
Yeah, particularly in OTPs are policy-based, regulation-based.
right, right. Okay, and so finally, what is one system or policy level change you would like to see to improve the care of older adults in opioid treatment programs? So kind of taking a step back and just saying, what change would you like to see?
I think that in terms of policies, there have been efforts around more formally integrating medical care, or the rest of medical care and methadone care. And I think especially we talked about either integrating, medical care into the OTPs or taking things like methadone outside of the OTPs. So like office-based methadone where you can have it be prescribed for opioid use disorder by your geriatrician or palliative care. A lot of, times we talk about there isn't really a way to graduate, quote unquote, from the OTP. And so, we talked a lot about kind of some of the physical space barriers. And so I think innovations around that, though I think, COVID had helped us some with some of those innovations, like, mobile delivery vans or, some of that take home expansion. But I think more ways to directly have people have better access to both medical care and methadone for opioid use disorder is an area where we really could improve on in the United States.
Yeah, the regulatory structure is really key to this. What can we do? We did, as Zoe's mentioning, we did do a lot of work through COVID and relaxing a lot of the policies, but, stop treating methadone like plutonium. It's a medication. It's a life-saving medication that's highly stigmatized that, because of how we have treated it, people are reluctant to use it. There's a lot of misconceptions about it. There's a lot of fears around it, and it's so underutilized as a result.
So thank you both so much for joining us today, Kathy and Zoe. We really appreciate your time, expertise, and the care you provide older adults with opioid use disorder. Before we wrap up, I want to highlight a few key takeaways from today's conversation. The first is older adults who receive care in opioid treatment programs often experience logistical challenges in accessing their treatment for opioid use disorder and managing their other chronic diseases. Second, older adults with opioid use disorder often require an integrated and coordinated approach to their healthcare, and using the age-friendly framework in opioid treatment programs can help address the complexity of care for this population. And finally, there are current strategies, some of which we talked today, including the use of medical exemptions and actively coordinating care that can be utilized in the opioid treatment program setting that can provide age-friendly care to patients. And to our listeners, thank you for spending time with us today. If you found this episode helpful, we encourage you to share it with a colleague or someone in your network. Thank you.
That was Dr. Zoe Weinstein and Dr. Kathy Eggert in conversation with Dr. Benjamin Hahn on substance use across the lifespan, supporting every stage. Thank you to Dr. Hahn, Dr. Weinstein, and Dr. Eggert for this important conversation. And thank you for listening. We invite you to continue your learning with this episode's companion toolkit and live workshop. You can download the toolkit by completing the episode's evaluation survey and then join us for the workshop, where we'll take a deeper dive into improving care transitions and expanding support for older adults in skilled nursing and post-acute care settings. You'll find both the survey and workshop registration links in the show notes and at immersa.org. We hope you'll tune in next month for the next episode of Substance Use Across the Lifespan, when we welcome Gabriela Zapata Alma, Heather Phillips, and Dr. Jimena Levander to explore how substance use coercion intersects with intimate partner violence and how cross-sector collaboration can strengthen support for survivors and their families. In the meantime, join us in 2 weeks for the next installment of EMRSA's other podcast series, Frontiers in Substance Use Care, Emerging Topics and Evidence, where we explore the evolving landscape of substance use and addiction care. This EMRSA podcast series is created in partnership with the Opioid Response Network. To learn more about Opioid Response Network and EMRSA, please visit opioidresponsenetwork.org and emersa.org. Technical production is provided by Podpaste. Funding for this initiative was made possible, in part, by grant number 1H79TI088037 from SAMHSA. The views expressed in this podcast do not necessarily reflect the official policies of the Department of Health and Human Services, nor does mention of trade names or organizations imply endorsement by the U.S. government. Disclaimer. The information, opinions, and recommendations presented in this podcast are for general informational purposes only and should not be considered medical advice. This podcast is not intended to replace professional medical consultation, diagnosis, or treatment. Any reliance on the information provided in this podcast is at your own discretion. While every effort is made to present accurate and up-to-date information, EMRSA makes no warranty, guarantee, or representation regarding the accuracy or sufficiency of the content featured. The views expressed by guests are their own and do not necessarily reflect the views of EMRSA. Their appearance on this podcast does not imply an endorsement by EMRSA of them, their viewpoints, or any entity they represent. Unless explicitly stated otherwise, EMRSA does not endorse, approve, recommend, or certify any information, product, process, service, or organization mentioned in this podcast. Information from this podcast should not be referenced in any way that implies such approval or endorsement. EMRSA expressly disclaims all liability for any direct, indirect, incidental, or other damages resulting from an individual's use of, preference to, reliance on, or inability to use this podcast or the information presented in it.